All right.
That's
Hello,
great.
everyone. I will begin. Thank you so much for joining us today. We are covering the Oyster Care Model, nurturing a patient-centered healthcare system. And we have two wonderful international panelists, Dr. Loic Moreau and Dr. Ilse Decourt, that are joining us today. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Ottawa, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original people in what we now know as Canada. We are grateful to have the opportunity to be present in this territory. So briefly, the Palliative Care ECHO project is a 5-year national initiative to cultivate communities of practice and establish continuing professional development among healthcare providers across Canada who care for patients with life-limiting illness and their families. I invite you to go check us out at www.echopalliative.com. A little link has been shared with you in the chat. And the Palliative Care ECHO project is supported by a financial contribution from Health Canada. So the views expressed herein do not necessarily represent the views of Health Canada. Briefly, some of you might know us for our LEAP courses that we offer at Pallium. And one of our top selling courses is our LEAP Core course that I invite you to learn more about at the link that is shared with you. It is an interprofessional course that focuses on the essential competencies to provide a palliative care approach, delivered online, or it can be delivered face-to-face, and accredited by the College of Family Physicians of Canada, as well as the Royal College. A couple of welcome and reminders. So we ask that you please introduce yourself in the chat. Let us know, what country, province, where you are joining from, and what your role or your setting of work is. Your microphones are going to be muted. There will be a time during the end of the session or during the session as well, if you wish, that you can unmute yourself for questions and discussions. But I do invite everybody to please indicate your questions in the Q&A function, and all of your questions will be addressed at the end of the presentation. This session is, of course, being recorded and will be emailed to registrants within the next week. Remember not to disclose any personal health information during the session. And brief disclosures. So Pallium Canada is a non-for-profit organization funded by Health Canada, as mentioned before. And we also generate funds to support operations and research and development from the Pallium pocketbook sales and course registration fees. The Scientific Planning Committee has completed independent control over the development, of course, of any content that you see with us today. I myself have nothing to disclose. And for our two presenters, you may consult the slide that you see before you for their disclosures. So once again, my name is Diana Vince. I'm the Palliative Care ECHO Project Manager at Pallium Canada, and I will pass it on to Loic to allow him to present himself. You're on mute. You're on mute, Loic.
Okay, sorry for that.
Okay,
so thank you, Diana, and thank you everyone for having us today. It's a wonderful opportunity. First of all, I would like to apologize. Neither Ilse nor I are native speakers. For us, this is our third language, so we will probably make a couple of mistakes. Please excuse us for that. I am working at the KU Leuven, that's a university here in Belgium. I am working on a project that relates to the ethical aspects of end-of-life care for people with severe and persistent mental illness. I am also working as an ethicist for a hospital group here in Belgium, in Flanders, specialized in mental health care. And I now give the floor to Ilse to introduce herself.
Hello, everyone. I'm a general practitioner and I work in Geel. I work there on a care unit with people with SPMI, so people with severe and persistent mental illness. But I have, in fact, two jobs. My other job is I'm also a doctor, a physician in palliative care, and I work in an other hospital on a palliative care unit. I work and in the psychiatry and also in the palliative care.
Fantastic. Welcome to you both. And I will now pass it along to Loic to continue this wonderful presentation.
Okay, thank you. So today we will be talking about Oyster Care. It's a care model that's actually uses the palliative philosophy. We call it a palliative care approach for people with a severe and persistent mental illness. So just to give you a brief idea where to place this model, I'd like to explore together with you the crossroads between mental health care, psychiatry on the one hand, and end-of-life care on the other. And I made this structure to make things more clear for me, and apparently many people liked it. So I will briefly describe 5 encounters for you. So the first encounter, I think, is a patient group that is well known to you guys, are those patients who are actually in a palliative stage, and they develop some psychiatric symptoms on top of that. For example, anxiety, depression, delusions, and so on. I think this is a group that also in the scientific literature is well known, and I think that we as caregivers have already the past few years tried to adapt our way of caregiving to these specific needs. So I think this is a first rather well-known group. Then we have a group that is actually a little bit of a mirror to the first group, and those are the psychiatric patients. So people actually who live within the mental health care hospitals or other care units, but they develop a life-threatening condition, for example, cancer. I think from my experience, this is a group that encounter a lot of problems in the care. Sorry, this is my English not being very well. So they encounter several problems because, well, in our experience, at least in Flanders, in Belgium, the psychiatric hospitals are not that well equipped to deal with palliative patients. In general, the somatic care is not well developed within psychiatric hospitals. There are some differences, but this makes that people actually having a life-threatening condition within the context of mental health care often encounter problems receiving the most optimal care. So that's a second patient group. A third patient group are those patients with a psychiatric disorder who enter a terminal phase because of this specific disorder. And I think I see 2 patient populations here. For example, the people with anorexia nervosa, but a very refractory form. And so because they suffer from this illness for a long time, they have, for example, their organs don't function as well anymore, and so they become in effect in a terminal phase. Also, there are some people, for example, with chronic suicidality. I would also say they belong to this patient group. This is luckily a rather small patient group, but they really tend to have an enormous effect on caregivers and on the care system. And it's also very difficult to treat these people adequately. And it also raises several ethical questions with regard to, can we, for example, provide palliative care, palliative sedation for those people or not? Then a fourth group or population are those people requesting euthanasia or other forms of medically assistance in dying due to unbearable and incurable mental suffering. As you may know, Belgium is one of the few countries who actually has a law regarding euthanasia and also regarding people who have a psychiatric illness requesting euthanasia. We have this law for over 20 years now, so there is still a lot of debate going on how to do this properly, if it is even ethically correct to do this, and so on. But if I'm not, if I'm correct, Canada is also thinking about passing legislation regarding euthanasia and also regarding psychiatry. So this is a very, very challenging debate as well. And then lastly, we come to the patient group that we are discussing actually today. And those are the persons with severe and persistent psychiatric illness who actually have no treatment options left. In the last couple of years, there is some literature using the concept of futility in these cases. So these are people who actually suffer from one or more psychiatric diseases for a very long time, who where we have tried lots of things to help them with medication, with therapy, and so on, but nothing really seems to help. Nothing really significantly and structurally seems to help to alleviate the quality of life for those people. And so for those people, we try to invent a care model that actually tries to integrate the philosophy or some aspects of palliative care or the palliative philosophy. And so we call it a palliative care approach. And now I will give the floor to Ilse to talk about the care model.
Okay. In Yale, where I worked with patients with a severe and persistent mental illness, there I came to the idea, I felt the need to look for a new care model, and I came to the idea of Oyster Care. Then I didn't develop the idea myself. I got help from Dr. Françoise Verfailles. She's a psychiatrist who works in Bruges, also in Flanders. And there was also the Forum of End of Life and Psychiatry. That's something that's originate from the Federation of Palliative Care Flanders, and there where I met Loïc. So yeah, in the beginning, I was working on the care unit, and to me, it seemed a bit that the people with SPMI, they were forgotten. They seem to be forgotten. They were forgotten by the system of psychiatry. They were forgotten by science because there was no investigation, no ever in those people. They were forgotten by the government and the hospital because there was few investment in the people. The people got very low supply of care. They got very limited therapeutic support, and they had really poor infrastructure when I arrived at the care unit. And however, those people had complex problems and high care needs. So I wanted to do something. And in the past, those people had a lot of therapies, but the therapies weren't very successful. And during the years, they saw the symptoms of the people getting stronger. So the behavior problems became worse and more destructive to themselves, but also destructive to other people. So they seem to need permanent residential support, and that's what they get with us. In fact, they came in to our care unit for that permanent residential support because they couldn't go back to society. And to me, they looked very alike the oncological patients from the past century. When a patient got to hear, well, your chemotherapy has ended, a pity for you, it doesn't work, and now there's nothing more we can do for you. And in fact, people with SPMI are a bit in the same position. So they were told, we can't do anything more for you. That's why we talk a bit about the fertility and the risking of both negligence or overtreatment. But we all know with oncological patients of the past century, that's when palliative care starts. Palliative care starts, it has born between therapeutic stubbornness and therapeutic nihilism. And therapeutic palliative care, what does that do? It changes the focus. It changes the focus from cure to care. Well, that's now exactly what we need to do for people with SPMI, because there are people with high suffering. So we should make the focus on making their suffering more tolerable. We should put the focus on harm reduction. And just as the oncological patients who had ended their oncological therapy, we have to replace the focus from cure to care. And that means we have to improve the quality of life as the main focus of care. We have to help them to build or maintain a meaningful existence and supporting with their mourning processes, because the people with SPMI, they have had a lot of loss in their lives. They also need a holistic care because their needs of those people are not only on the biomedical needs, but they have needs on different areas in their life, just as palliative care people who need palliative care also needs care on the different areas in their lives. But to do that, we have to reinvent the care, and we have to be very creative, because everything what has already been known, everything from evidence-based protocols and guidelines has already been tried and it didn't work. So we have to think out of the box. We have to be very creative. That's the beginning of the crustative zorg. Because in the beginning, I thought I call it palliative psychiatry, but I got a lot of comments because people says that's too much connotation with giving up and dying. So I thought I invent a new name. And maybe you know, but palliative care comes, pallium is cloak in Latin, crustative zorg, so crustative care. Crusta is shell in Latin. So I thought that's a bit alike, a shell like a firm cloak. So Oyster Care offers an answer to the care units, the care needs of patients with serious psychiatric illness who appear to have no more valid treatment option left, who suffer from severe mental illness, for whom recovery is not feasible, who need permanent intensive treatment, and who are in danger of being forgotten by the government as within the healthcare system. Another reason why I called it crustative care in Dutch, so is because of this shell, the crusta, the shell, because the external structure given by the care, offered by the care unit itself, it functions as a shell. And within the shell, the people with SPMI, they feel themselves safe, and there they can function, there they can live. So we protect the people with a shell in which they know themselves safe. And at the same time, the term refers to the care unit in a hospital, which, like an external skeleton, gives meaning and structure to these patients. Oyster Care is certainly a dynamic approach. It responds to the needs, possibilities, and pace of each patient. So sometimes psychiatric disease predominates, then the needs are more high from the people, and then the shell, people need more shelter, the shell closes, but there are also times that the psychiatric disease goes more on the background, that people have more possibilities, and then the shell can open more. So depending on the current situation. Back to Loic.
Thank you, Ilse. I just wanted to tell some anecdotes, really, but I think it's an important one. You saw a struggle with the term crustative care and so on. So in Belgium, crustatieve zorg or schelpzorg, which translates to shell care, doesn't really ring a negative bell. But a couple of years ago, we went to Switzerland to talk with some of our colleagues who are also involved in psychiatry and palliative care, the Professor Traxel and so on, Manuel Traxel. Yeah, we came we came to them with crustative care, and of course you guys know a lot better than we do that it doesn't ring very well. A crust apparently is something not very beautiful to look on or to look at, and also when we try to amend to stepping over to shell care, then well, on the one hand we had some kind of oil conglomerate on the one hand, or even a shell is also a kind of a bomb. So that didn't sound that well. So actually, one of the psychiatrists there came up with the term that we currently use, namely oyster care. And it actually has a nice advantage over shell care, namely that there is, well, we associated oysters with a pearl, and well, you can of course translate it like, oh, the pearl is some kind of treasure. It's the patient that should be treasured, or it's our care that's a treasure, and you can do that, of course. But if we switch to our biology lessons for a couple of minutes, then actually, what is a pearl? A pearl is a little bit of sand that actually penetrates the outside, the shell of the oyster, and actually hurts the oyster. That's a really vulnerable thing in itself. And so what is the pearl? Is actually it's a coping mechanism from the oyster to deal with this hurt, actually. And I think it's a really beautiful metaphor if we can think of our model, but also as the shell and the pearl, not only as some kind of treasure or something that has to be treasured, and of course it's that as well, but it's also coping with suffering. And I think that makes the metaphor really rich. Okay. So far for the anecdotes. So what we are going to do now, actually, we will try to present the model on the basis of 4 pillars, as we know them from palliative care: the somatic pillar, the mental pillar, social pillar, and the existential pillar. So we will try to give you some idea of the challenges that we face and how we try to deal with them from an Oyster Care model perspective. We will also present 2 cases, so you can taste a little that how we actually deal with the people, and we will conclude the presentation with some challenges and future goals for the model, and of course the Q&A. So I will give the floor back to Ilse to present the first pillar, and that's the somatic pillar.
Okay, thank you. First, I'm going to tell you the story of Liz. And Liz has been a real inspiration for me. She's really on the, in the beginning of the Oyster Care, she was my big inspiration. And this story, that's why I like to tell you also her story. Liz had a history of long admissions in different hospitals and wards. At the beginning of the story, she's 66 years old. She has a lot of behavior problems, and we see more and more regression. And we see she cramped her muscles like that. And then she says, I can't. And she says that 100 times. And well, she refuses help from us. And then she began to fall. And we don't know why she falls. There doesn't seem to be a somatic reason. And she got a lot of fractures, amongst others in her hands. But she doesn't mention pain. And we don't see in time that she has fractures. We discover it too late. Then eventually we put a plaster on her hands, but after the plaster it has removed, she refuses to move her hands, and now the hands are really in contraction. So she can't use them anymore. And then there's another fall, and that other fall results in a spinal fracture. And of course, that's very dangerous. There's a danger of that the legs get paralyzed. And we say to her, Liz, look, we think it's best that we're going to fixate you during 6 weeks until your fracture has healed. And at the evening of her fall, she says to us, I agree, because look at my hands. If I had listened to you, then yeah, I could use my hands now, but it was so much stronger than myself. And I'm afraid this time it's going to happen again. So I give you the permission to fixate me during 6 weeks. Now, we did that, but the first evening was the only evening that she did give her permission. After that, she really resisted to us. So we fixate her in an easy chair in the middle of the care unit. She wasn't alone in a room. She really got company. And our direction from the hospital got us more staff, so we could organize a one-to-one approach. And then we let the focus on well-being. In fact, she was the first person who really received the curative care or the Oyster Care. And she changed during those 6 weeks. And after the 6 weeks, we didn't saw only that the spinal fracture was healed, but there were also less behavior problems. There was no more falling. There was less suffering and a lot of more well-being. Yeah. So if I look to the somatic pillar, then there's a problem there because people with SPMI do have a shorter life expectancy, and they live 10 to 20 years less longer compared to the general population. That's a lot. They also have somatic comorbidity linked to the psychopathology and also to their treatment and their lifestyle. They got a lot of polymedication during very, very long time. Medication is very high dosed. So there's few investigation. What does that do? And what does that have from an effect on a body, on brains? We expect it doesn't do very good. We expect very bad results from taking during so many years such high dose of psychopathological medication. But also people have an unhealthy lifestyle. And maybe something you don't know is that we lost a lot of people with SPMI from choking. Because they develop a different way of eating. We call it the fast food syndrome. They eat very, very, very fast. And that makes them have an increased risk of choking or suffocation. They also have limited access to somatic treatment and follow-up treatment. Sometimes that's due to stigma that exists in the somatic hospitals. But sometimes that's also because of the patients. They can't follow instructions like don't move during an investigation, or their behavior problems are too big for some somatic treatment, or people doesn't want treatment because of their psychiatric disease. So physical signals are often not correctly interpreted by the caregivers. And that's because it's very simple. If I can remind you of the story of Liz. Liz fell. Why? Normally you think falling that should have a somatic cause, but in Liz, her case, it didn't have a somatic cause. It was due to the psychiatric disease. And sometimes it's the inverse. So you see behavior problems, and then you have to search, or you see organic problems, and then you have to search. What is the cause? Is it psychiatric or is it somatic? somatical. So you never know, and it's sometimes very difficult to get known. And also those people, they have a different bodily experience, and that results in a different pain experience. People with SPMI, you don't see that they are in pain. They don't show it emotionally, and they won't tell you either. Like Liz didn't do it after her falls. So pain, but also other physical complaints are expressed differently and experienced differently. And that makes that we don't recognize them. And so you got undertreated disease. Yeah. So what we need in Oyster Care, we need a very good somatic care and treatment individually tailored to the patient. There should be a close collaboration between the psychiatrist and general practitioner, and the general practitioner, as I am, should be part of the care team. I think everybody in the team should know what total pain is, because total pain, you know it in palliative care, and I think that's a concept that's very important for SPMI people. Pain is there seldom only something that's important on the somatic pillar, but pain is always influenced by the other pillars. And I think everyone should realize that. What we also have, we have a high care for meals. We have one-to-one supervision, also because professions like the therapists or the psychologist, they also they help with the meals to make sure that people don't choke. Our psychiatrist, she makes sure she has a continuous follow-up from the psychopharmacological therapy. So she has a continuous follow-up and evaluation. And it's very difficult to maintain a good balance between treating symptoms. Therefore, medication is dosed very high. And then also, yeah, there are we have to limiting the side effects, and there are a lot of side effects. So as to the sides, we can say that the care unit works as a shell. It tries to preserve the physical integrity, like we did with Liz during the 6 weeks of fixation, but it's not the fixation that's the most important. It's the one-to-one approach with the focus on well-being that made her a lot better, sorry. Yeah. Loic?
Okay, thank you. So the second pillar is the mental pillar. So you can imagine that people with severe persistent mental illness have major psychological frailty due, well, high sensitivity to stress. They also have serious information processing disorders. So I have a small attention span. Sometimes they have memory problems. So they often have a strong hypersensitivity to overstimulation. So we have to be really careful with what kind of stimuli we are giving. They have serious problems with the processing of stimuli, as I said, and the regulation of stress. They also have serious discomfort because of delusions, hallucinations, agonizing thoughts, negative emotions. For example, you can imagine that when someone continuously experiences voices in his or her head telling negative thoughts, that this is, of course, very painful to deal with. Oftentimes, those people also have a limited illness insight, so it makes it harder to, also as a caregiver, to provide good care for those people. They also have limited ability to introspection, mentalization, reduced problem-solving capacity. Maybe also here, I'd like to tell an anecdote. So a couple of months ago, I was in the care ward, and one of the patients fell right in front of me. I tried to lift her up. It didn't work. Okay, I did what I did best. So I went to one of the nurses and I asked her, please, can you help me? Because one of the patients fell and I can't get her up. And so the nurse really, she was very calm, and she just went to the patient, let's call her Mary, and she just said, well, Mary, okay, put your hand over there, put your knee over there, and just Mary just stood up all by herself. But So she couldn't do that on her own, not without the guidance of the nurse. But physically, she was totally capable of rising just by herself, but she couldn't do it without the help of the nurse, helping her cope with the situation. They also have reduced emotion regulation and behavior control, negative self-image and disturbed body experience, as Ilse also already said. Also, they have major psychological insecurity in contact with others due to severe trauma, severe attachment problems, and serious difficulties to build up a relationship of trust with other people, and we will get back to that. So, what is our focus in Oyster Care? Well, I know these terms are very maybe philosophical, but I think they really matter. We have to try to be very patient and persistent in finding ways to build a positive relationship with the patients. I guess you already grasped that giving care for those people is different from the rather the treatments that have shorter. I'm sorry, my daughter came to say hello, and I was a little bit disturbed. So that it's different caring for those people for a very long time than caring for people when you only have to care for them a couple of weeks or a couple of months, like in most cases. The caregivers as well have to be have different virtues or have a different starting point. So we try to also continue to offer the patient the chance to attach himself to the caregivers at their own paces. We persevere, in assisting the patient in a creative way that is unique to each patient. So it's really one-on-one. It's not one size fits all. I think that's also a thing that we have in common with the regular palliative care. We try to strive for an optimal supply of contact and stimulus. And we also strive to maintain a good balance between distance, letting go, giving space, self-determination, and proximity, structuring, holding, and limiting. We also try to be present. I think in the Netherlands and in Belgium, we know the presentie theory of Andries Baart. He's really very well known over here. So it's about the quality of being there, being in the care relationship. So we also try to have a good view of the patient's way of communicating and the meaning of often nonverbal signals. I also noticed in many cases also during my research that many of those people can't communicate that well, or have actually a language that is very specific to themselves, and oftentimes only the caregivers and some family members actually really understand them. So it takes time to get to know the patients and try to communicate on their own level. We also try to sense and understand what cannot be said or experienced, but is expressed in strange or unwanted behavior. As Ilse, I think, illustrated very, very well with the case of Liz, is that well, sometimes the patients show some kind of behavior that is unwanted or strange, but they try to tell us something in that way, and so we have to be creative and finding out what does this really mean. So the role of the care provider is to care and to provide emotional safety from his or her person, and to structure that makes a connection with the patient possible. And the importance also of a good therapeutic attitude, of course, is very, very crucial. Maybe a last thing that I want to mention is positive risk taking. As you also grasped that, well, if people oftentimes show behavior that is disturbing or possibly even dangerous to themselves or others, then within mental health care, that we often try to restrict that kind of behavior, and sometimes even use coercion that has really traumatizing effects on the patients, but also on the caregivers and maybe other people involved. So we really try to start from a point of positive risk-taking, giving trust to our people, but also, of course, and it's also very important to try to keep it safe, but we try to adjust the care ward as much as we can to the person, to the patient, and not the other way around, because that's most of the times that's a starting point for other psychotherapy, that we try to reintegrate the people within society and so on. But in those care wards, we try to adjust the care ward to them. Okay, the social pillar, Ilse.
Okay, back to me now. For the social pillar, so people with SPMI, they have often serious communicative and social difficulties, and that results that they have a limited social network and they risk to get isolated. Often they think hospital is their home, and their important and meaningful bonds is with caregivers, because patients' relationships with relatives have usually been damaged or lost because of their long history of illness. A beautiful sentence from a therapist, Doortje Kaul, says, the contact with society is interrupted. They stay inside because it hurts to be outside. And I think it's very true. Yeah. The focus in Oyster Care. So the caregivers create a reliable environment or an exoskeleton, which offers opportunities for encountering other people, and where being strange or out of the ordinary is recognized, respected, and tolerated. So the caregivers are as tolerant of strange behavior as possible, as long as the situation remains safe for the patient and the surrounding patients and the staff, of course. So the role of the care provider is ensure recognizability and predictability, for instance, by offering a daytime program, and to be available in a sensitive and respectful way, and to continue to invest in being a social role model for the patients, in fact. Also, he has to invest in the care for relatives and friends. What's also important is that the care provider support the patients in taking on and maintaining roles other than the role of patients. But they do that by being present in their lives and undertaking activities together. But also, for instance, a nurse told Liz about her own boy. Her son had a traffic accident and was in a hospital. And like that, she supports Liz of taking on another role than just being patient, because Liz is a very caring and warm person. So every time she sees the nurse now, Liz says, "How's your son?" And that part is very important for Liz, that she can be not only patient, but also be someone else. So social rehabilitation is not a goal in itself, but the caregivers support the patient's desire to belong and to live in a meaningful way, like in the example with Liz. The caregivers fight also against the process of marginalization and exclusion. They do that within the care unit, but also in the hospital and in the outside world. So they form the bridge between patients and the world around them. Thus the care provider is really a bridge builder. So I can illustrate you that with the story of Robert. Robert is a man from 52 years old, and he's an autistic man with very severe behavior problems. What does? He drinks a lot of coffee and spills also a lot of coffee on the floor, not only in our care unit, but also in the rest of the building. So he turns each coffee room into a coffee swimming pool. He also picks up butts, cigarettes from the ground, and he eats them. And in the past, there has been tried with freedom restrictive measures, but it led to a lot of loss of well-being, and they didn't have effect at all. So what is now Oyster Care? Oyster Care is that we change it. We adapt the environment to Robert instead of Robert to this environment. How did we did that? Robert got on the care unit his own coffee corner where he could spill a lot of coffee. But also that's an example where the caregivers have really built the bridge, because we went to the other staff members and asked them to lock the rest of the coffee rooms in the building. And in the beginning, we got a lot of resistance and people thought, whoa, why we should do that? Just put more freedom restrictive measures again to Robert and the problem has solved. But in the end, they locked the rooms. So Robert learned to stay in his own coffee corner. We also decided that he should drink his coffee with milk, because otherwise he drank his coffee, hot coffee in once, and then he risked to burn his throat. And we gave him also fresh cigarettes to eat, because we thought it was better that he eat fresh cigarettes from a box than he picked it up butts from the ground. And we saw already an improvement in Robert's well-being. So he was already a lot more happier. And then our psychiatrist thought that maybe methylphenidate could work, because Robert seemed to calm down from coffee and cigarettes. So maybe he calmed down also from methylphenidate. And in fact, it succeeded well. So in fact, that's an example how in prestative in Oyster Care, we use medication also of label, like we do also in palliative care. So for the moment, Robert still lives with us and he's a happy man.
Okay. And lastly, the existential pillar. And once again, I'm actually mad at myself for not starting with this pillar, because as we all know that if we are providing holistic care, then the existential aspect of care and life are very crucial. And so we all say it's very important, but actually it's for many people, it's one of the most difficult things to actually give hands within healthcare. So as you can imagine, people with severe and persistent mental illness have experienced many loss experiences. They suffer from, but also under the effects of the disease. It's not only the disease itself, but of course, because of being ill so many years, they often don't have the relationship that they imagined they would have, or the children. They don't have a career as they wanted to. So all those things, they suffer from them as well. Working with those people, we stand in confrontation with the frailty and the brokenness of life. Feelings of hopelessness, injustice, senselessness often arise, and of course this can be explicit in words, but also implicit, for example, due to inactivity. And so feelings of powerlessness, both in patients, family, and caregivers, I think are rather common. Oh, this is one too many. So what do we try to do in Oyster Care is, first of all, try to be sensitive and open to the existential themes, like death, like meaning of life, but also trying to find a balance between freedom and autonomy and restriction. Also daring to deal with and being able to deal with statements of meaninglessness. So we try to provide extra courses, for example, for our care providers to have a language to actually talk about those themes. remaining present even when powerless. I think that is so valuable as well. And of course, addressing power sources, such as the often remarkable will to live within those people. And maybe another anecdote that maybe you will find interesting or remarkable, that when we actually look at the population in Belgium who asks for euthanasia, it is often not those people with SPMI who request euthanasia, even though they suffer the most. If we see, if we look into the population who actually asks and receives euthanasia on the basis of psychiatric illness, those are people who are very ill, but are, relatively speaking, rather young, higher educated, and have a social network. Those people with severe persistent mental illness, well, they often have a very remarkable will to live and are not those people who request euthanasia. Oyster Care also focuses on helping patients try to connect with themselves, to others, to nature, and to the sacred in their lives through meaningful and well-being activities that we also sometimes provide for them. So we also try to search in word and deed for the essence of the person, for a remaining seed of meaning and self-esteem, and try to stimulate them to let it grow. And also, well, we have to take care of the care providers and caregivers as well, of course, because it is not so easy to care for a long time, as I already mentioned, for those people, and also cope with those feelings of hopelessness and meaninglessness. And so we try to provide supports also to each other from a position of not knowing and being non-judgmental. Okay, so I also already saw that there was a comment, and how do we finance this model? So I will go into that. Because of course it's a model that is in continuous development. It's not been around that long, so we have some future goals, but also obstacles. So I will go over them briefly. Oyster Care, as we know it today, is actually being provided in some hospitals who make a choice to actually care for this target group and do it in another way than we are used to. But it's not the case that government or the Belgian government provides extra funds to make this happen. We hope that in the future this will be the case, but for now it's just the choice of a particular psychiatric hospital or group that likes to invest or wants to invest in this target group. In the future, we would like to have the structural recognition, expansion, and implementation of Oyster Care units throughout the country. We also need more studies regarding the actual care needs and the care complexity. Because, well, as Ilse also mentioned, the scientific literature with regard to those people is actually not that extensive. For example, especially qualitative research is very limited because many researchers think, well, it will be very difficult to obtain informed consent from those people, or communication will be difficult, especially when doing a regular interview. So oftentimes they just don't start and do research on another target group. So this is a vicious cycle that we have to break. Well, of course, being in a country that has a euthanasia law, maybe to a certain extent, Oyster Care can be an alternative for people with a request from euthanasia, even though I think it's not the complete picture. Well, training and recruitment, of course, is also very important. So I think that we expect a lot from the caregivers as well. So I think they have to be recruited in a different way, and they have to receive a lot of training and support. And of course, well, we have to be cautious with regard to several ethical aspects of care. So how and when do we apply coercion? How can we keep it safe for everyone? How do we cope with limited decision-making capacity? How do we assess that? And so we have to be very careful. So I think that as an ethicist myself, I think that we have to be very careful with regard to the ethical aspects of this care model. But so we have some milestones and achievements that we are rather proud of. So we have some publications now in local and in international literature. So we also have a forum where we bring together all the people involved within the care model. So we provide intervision groups, consultation. We developed a logo together with the patients. We have a website now also with several stories regarding the care, also from family members, also from patients. That's very nice. We actually won some awards, and we actually have a television series now. Of course, it's in Dutch, so I'm sorry, but it was very rewarding to do that and make our care model known to the broader world, so to say. So there is also intensification regarding the scientific research and this target group. So I think that's a great thing. And I think maybe even the most important thing with regard to Oyster Care is that it gives appreciation and recognition with regards to the care complexity and the role of caregivers. Those people often felt really neglected, also the caregivers within the healthcare system. And so ever since Oyster Care came up, those people felt recognized and seen. And I think that's a very beautiful thing. So I included some references for further reading. I think for the people who are English native speakers, and I think that's most of you, I think the article in Frontiers with regard to the model will be the most helpful one. And so I think it's time for a Q&A now. So Diana, I don't know if you will lead the Q&A or if we have to do it ourselves or...
No, it's okay. It's okay. I'm right here. So we do have a question in the Q&A about how can you afford to staff with the demands of one-on-one care? What is your funding model?
Yeah, so we can't actually, right? So as I said, we start from the care wards that were already there, and they have actually very low funding in Belgium. It's a different, and I think it's a different case country by country or region by region. For example, in the Netherlands, this target group receives very, very extensive funding, but in Belgium that's not the case. So it's really some of the care hospitals who actually make the choice to invest more in the target group, and so we try to invest in specific moments, of course, on one-on-one in therapies and so on, but also during the meals and so on. So then we can really work one-on-one, but we can't do this all the time. And this is, of course, a frustration. And so we try to achieve more funding by the government and so on, but it's not structurally there yet.
Yeah.
We also try to work with volunteers. That's something in Geel that already happens.
Mm-hmm.
And volunteers have they do work sometimes because with a volunteer, that's somebody from outside. So the patient, it puts himself in another role than being patient. So mostly they behave very well with the volunteers. They give the best of themselves. And like the story of Liz, we got one-on-one approach. We got extra staff for 6 weeks. It was not that extra staff could stay afterwards. So sometimes when we have really a difficult situation, we can ask an extra person in the staff, but that's limited. That's not always like that.
Yeah. Thank you so much for answering that. And thank you so much for everybody attending today. Unfortunately, the 1 hour, it really did pass by really, really quickly. We invite you to fill out our feedback survey. A link has been added into the chat. And like I mentioned before, a recording of the session will be emailed to registrants within the next week. Thank you once again for your participation. And we hope to see you again very soon. Thank you.
Thanks.
Bye.